My name is Dr. Arushi. I am a consultant. I'm working as consultant in radiology and fetal medicine at Levasa Superspeciality Hospital, Mohali. And these are my areas of interest, right? So this is my second class. No, so this is my third class actually. And the topic today is imaging and fertility. So this is a big topic, right? It has got multiple parts, and I'm going to take it in parts because every part itself is like a topic, right? So in order to have a good discussion about each part, today we are discussing about part one, and we are going to start with what is infertility, right? So the definition of infertility is what we all must know. When the patient visits us, then we should know that what the patient is talking about. If the patient says infertility, whether the patient fits into the criteria of infertility or not, right? So, uh, by definition, if the patient is unable to conceive after 12 months of unprotected intercourse, it is called as infertility, right? The job of a clinician, of a clinical radiologist, is to identify the treatable causes and to guide the management, right? So, this is something which is important. So, we are going to go towards identifying the treatable causes and thereby radiologically guiding towards their management. So, we'll divide it into actually two parts. First of all, depending upon the etiological factors. So, the gender based classification is either the male etiological part or the female etiological part. And then we have the hormonal causes, which again could be divided into two parts like male and female, right? So now female morphological causes, something that comes to us for imaging. Okay, includes, I've divided it into four parts, right? So ovaries, uterus, the tubes which connect the uterus to the ovaries, cervix and vagina. What today we are going to discuss is about the ovaries, and we are going to go ahead with the case scenarios, right? So specifically, we are going to talk about the ovarian scenarios which cause infertility, and which could be diagnosed on imaging, which are radiologically important for which the patient might come to us. So we are going to go ahead with case scenario one, and we have a 15-year-old female patient with normal secondary sexual characters, but she complains of amenorrhea slash she has not achieved menarche yet. So my first question to you is whether it is primary or secondary amenorrhea. And my second question is how would you like to evaluate? Please put up your answers in the chat box. And I hope everybody is going to put answers in the chat box because that's how that's how it is like a two-way conversation. That's how it gets interesting. So don't shy off. So, okay. Opsonized Fago hasn't changed his name, right? His or her name. I don't even know. It's still opsonized Fago. Okay. So, the kind of the amenorrhea that we are talking about is a primary amenorrhea, right? And um, as per a few of you, the modality of choice is going to be ultrasound. So, like the first modality, I would not say modality of choice, but the next modality that the first line of investigation or the modality will be an ultrasound. That's correct. So primary amenorrhea, by definition, is having no history of menstruation by the age of 15 years or 3 years after having breast development or thelarche, right? This is something that we must know clinically. And secondary amenorrhea is defined as absence of menstruation for more than 3 months in a woman with previously regular cycles. So yeah, so if she had regular cycles, then 3 months enough, or she should have a 6 months of amenorrhea in any women who actually had at least one previous spontaneous menstruation. So maybe for irregular cycles, you can consider 6 months. Or if the patient comes and says, I was having regular cycles, but since 3 months I've not had them, then it goes into the category of secondary amenorrhea. Right. So the clinical scenario, the case scenario that we are talking about is a primary amenorrhea. Correct. So now let's move ahead. We do an ultrasound and we see these tiny structures, right? So what are we looking at? What are we looking at? Ovaries. So do they look normal or do they look abnormal? So in terms of size wise, if you're, yeah, so they look atrophic, they look small in size. They're like almost 1 centimeters. They're very small in size, right? So any clues where we are heading to? What would you like to put up in your report? Streak ovaries, very good. And streak ovaries and? So what would you like to see in the patient morphologically? Turners, very good. What are the features of Turners? What would you like to see morphologically in that patient? Web neck, perfect. Short stature, perfect. So that's something that when the patient walks into your room, low hairline, very good. So hairline is something you might not have focused on first, yeah. But then short stature is something that is something that you can see very well when the patient walks into your room, right? So always keep an eye, keep an eagle's eye when somebody comes into your room. A lot of diagnosis could be made then, right? So this patient, when came into your room, was definitely short statured, was having a webbed neck, and then we saw these ovaries, and she complains of primary amenorrhea. So maybe we are moving ahead with Turner's, right? Okay. So ovarian causes, when we are talking about, we have seen that what we imaged as streak ovaries look very small, atrophic, and they do not contain, or maybe you can see few follicles, you might not see any follicles at all, right? And at times they might be very difficult to identify or locate on ultrasound, and that makes it a case for MRI. Then you can move ahead with MR imaging. So the first line of imaging is definitely ultrasound, followed by, if you want to go ahead, then you can move ahead. If you're not able to locate, then move ahead with MRI. So this is something that these patients present with, and it's important to know morphologically. At times, what happens is the referring doctor has also not noticed, and it is you who is working as like a referring as a primary clinician and as well as somebody who is scanning, right? So what when the patient walks in, obviously short stature, a very broad chest, right? And something that is appealing is a webbed neck, right? So, what are the ovarian causes that can cause primary failure? So, this is known as primary ovarian insufficiency or a primary gonadal dysgenesis. And these chromosomal abnormalities are very commonly associated with them, which compromise of 45X, so a triple X or a trisomy X or a pure gonadal dysgenesis. All of these three are going to cause primary ovarian insufficiency. Right? Primary ovarian insufficiency is something which was like less than 40 years of age, presents with complete absence or maybe very poor menstruation cycles, oligomenorrhea, complaints of very significantly reduced blood flow, or amenorrhea, right? So this is something that we see clinically as symptomatically when the patient comes, and the hormonal levels is also something that we should know of. Sometimes the patient carries the report and shows you and tells you, ki, this is my hormonal report, this is the test that we have done, and these are my symptoms, right? So rather than writing correlate clinically, this is something that we know when we are seeing a patient of similar status. A low estradiol of less than 20, elevated gonadotropin, that is FSH, is raised, obviously because it is a primary failure, so the pituitary and hypothalamic axis tries to recuperate it. So a value of more than 20, low AMH levels which are less than 0.5, which indicate a very poor ovarian reserve, and low inhibin B levels. So these are some things that we should be aware of, right? So you can put up in your formats, wherever you save a format for something like this streak ovaries, you put up these values. So when somebody shows you the hormone levels, you can go and cross check it with that. So this is something that is primary ovarian insufficiency, a cause of infertility, right? The patient might be an unmarried female who presents with primary amenorrhea, or maybe a female who is married and comes to you and says that I'm not being able to conceive, and we have been trying for a few years. So this is something that clinches your diagnosis, right? Now we have another case scenario. We have a 19-year-old female, and she complains that she's having an amenorrhea since 7 months, right? So this is obviously what, a primary or a secondary? She says since 7